Welcome to Quick Medical Review, the podcast where we make complex medical topics simple, high yield, and exam ready. Today we're covering pneumothorax, a core respiratory and emergency medicine topic tested across USMLE, MRCP, PLAB, and SMLE. Let's get into it. A pneumothorax occurs when air enters the pleural space, the potential space between the visceral and parietal pleura. This disrupts the normal negative intrapleural pressure that keeps the lung expanded, causing partial or complete lung collapse. Primary spontaneous pneumothorax occurs without underlying lung disease. The classic patient is a tall, thin young male presenting with sudden onset pleuritic chest pain and breathlessness, often during physical activity. This is caused by rupture of small apical subpleural blebs. Secondary spontaneous pneumothorax occurs in patients with pre-existing lung disease. COPD is the most common cause in older patients. Other causes include asthma, cystic fibrosis, tuberculosis, and pneumocystis jirovecii, pneumonia in immunocompromised patients. Traumatic pneumothorax results from penetrating or blunt chest trauma. Iatrogenic pneumothorax can occur after central line insertion, lung biopsy, or mechanical ventilation. This is called barotrauma. Patients present with sudden pleuritic chest pain and dyspnoea. On examination, there is reduced breath sounds and hyperresonance to percussion on the affected side. Tracheal deviation is absent in a simple pneumothorax but present in tension pneumothorax. An erect posteranterior chest X-ray is the first-line investigation. Look for a visible pleural line with absent lung markings beyond it. Size is measured according to BTS guidelines, the horizontal distance from the lung edge to the chest wall at the level of the hilum. Less than 2 centimeters is considered small, 2 centimeters or more is large. CT thorax is more sensitive and can detect small pneumothoraces missed on plain film. It's particularly useful in trauma settings and for distinguishing pneumothorax from bullous disease. For primary spontaneous pneumothorax, if small and the patient is not breathless, conservative management with observation and outpatient follow-up in 2 to 4 weeks is appropriate. If large or symptomatic, needle aspiration is first line. Use a large bore cannula inserted into the second intercostal space in the midclavicular line. Aspirate up to 2.5 liters of air. If aspiration fails on 2 attempts, proceed to chest drain insertion. For secondary pneumothorax, the threshold for intervention is lower. If over 2 centimeters or the patient is breathless, a chest drain is usually required. Even small secondary pneumothoraces in patients over 50 with significant lung disease may need admission and close monitoring. Chest drains are inserted into the triangle of safety, bounded by the anterior border of latissimus dorsi, the lateral border of pectoralis major, and a horizontal line at the level of the fifth intercostal space. Insert just above the rib to avoid the neurovascular bundle running along each rib's inferior border. This is the emergency you must recognize. A tension pneumothorax occurs when a one-way valve mechanism allows air into the pleural space during inspiration but traps it during expiration. With each breath, pressure builds progressively. The clinical signs are tracheal deviation away from the affected side, absent breath sounds on the affected side, hyperresonance to percussion, hypotension, and tachycardia. This leads to mediastinal shift, kinking of the great vessels, and cardiovascular collapse. Example: tension pneumothorax is a clinical diagnosis. Do not delay treatment to obtain imaging. Immediate management is needle decompression. Insert a large bore cannula into the second intercostal space, midclavicular line on the affected side. This converts the tension pneumothorax to a simple pneumothorax. Follow with a definitive chest drain. Recurrence rates are high, around 30 to 50% for primary spontaneous pneumothorax. Advise patients to avoid flying until a chest X-ray confirms resolution. Typically wait at least 1 week after full resolution. Advise against scuba diving permanently unless the patient has had definitive surgical management. For recurrent pneumothorax, surgical options include video-assisted thoracoscopic surgery or VATS with pleurectomy or pleurodesis. Chemical pleurodesis using talc can also be performed via a chest drain. Rapid-fire summary. Classic patient: tall, thin young male with sudden chest pain. First-line investigation: erect PA chest X-ray. Size measurement: BTS 2 cm at the hilum, divide small from large. Primary: small, not breathless. Observe and follow up. Primary, large or symptomatic, needle aspiration first, then chest drain if fails. Tension pneumothorax. Clinical diagnosis: do not wait for imaging. Tension signs: tracheal deviation away, absent breath sounds, hypotension, tachycardia. Emergency treatment: needle decompression second intercostal space, midclavicular line. Chest drain site, triangle of safety. Insert above the rib to avoid the neurovascular bundle. No flying until resolution confirmed. No scuba diving without surgical management. That's your complete review of pneumothorax. Study smart, not hard. If you found this episode useful, subscribe, leave a review, and share it with your study group. This has been Quick Medical Review. See you in the next episode.